I am so excited for today's video because I'm going to be reacting to scenes from Grey's Anatomy, and I think that having been through various teaching hospitals throughout my training, making my way to become an assistant professor at a teaching hospital today, I have some sense of what's realistic and what's not and what's accurate when it comes to the medical content. So without further ado, I've got my handy dandy laptop right here with me, and let's just dive right in. So if you want to see more of these types of videos from me, please give this video a thumbs up and don't forget to subscribe by clicking the red subscribe button below. Also, if you want me to react to other things, please leave them in the comment section below. Now today I'm going to be reacting to scenes from season 1 episode 4 of Grey's Anatomy, old school Grey's Anatomy. I think I might have been in college or early on in med school when this came out. So in full disclosure, I've probably seen a handful of Grey's Anatomy episodes at that. Some of us just shy away from some of the medical shows. If we're working in the hospital, we might feel like, you know, we already have enough of this in our real lives, but I'm super excited to see what's up in here, but I don't have very much context of the backstory of Grey's Anatomy and all the characters, but I'm gonna be focusing on the accuracy and the reality of the situation.
Anyone seen the floor chart on the new admission?
You always come in like that, bang the light on?
You're Elizabeth Fallon?
What does my chart say?
It says you used to be a nurse here.
A scrub nurse.
So it's true, patients don't get very much rest in the hospital. We're constantly walking into the rooms. If it's not the doctor, then it's the nurse, then it's the x-ray technician, then it's the student, and then it's the phlebotomist. So it's nonstop interruptions, so I feel for patients when they don't get very much rest. And often when we're rounding, we go into the rooms very early in the morning because we want to be able to see the patient and have a plan for the rest of the day, and that's why we go into the room super early in the morning. It obviously can be pretty distressing.
And that you have abdominal mass consistent with pancreatic cancer?
Oh, and you are hoping they're gonna give me a Whipple. Pancreatic duodectomy.
So at this point, I don't know how she was diagnosed with the abdominal mass, but it seems that she already knows that we have a diagnosis of pancreatic cancer. We don't know what kind of pancreatic cancer it is. There are various different forms of pancreatic cancer, the most common type being pancreatic adenocarcinoma, but there are also other forms of pancreatic cancer like the neuroendocrine tumor, like what Steve Jobs suffered from. Now aside from Steve Jobs, there have also been several other big public figures who've also come forward with the diagnosis of pancreatic cancer, the late Aretha Franklin, as well as Alex Trebek recently coming forward with pancreatic cancer, and we're going to only see more cases of pancreatic cancer over time, unfortunately. Now what she's referring to, the Whipple procedure or the pancreaticoduodenectomy, she left out a couple syllables. The Whipple is one of the surgeries to remove pancreatic cancer if it's in the right location. Now, most commonly pancreatic cancer happens in what we call the head of the pancreas. So I'm gonna draw out the anatomy here for you guys. So first, I'm gonna draw out the stomach and the small intestine, the first part of the small intestine. So here we go. This is my very crude drawing. This is the esophagus, it goes into the stomach, and then the first part of the small intestine called the duodenum. And in the first part of the small intestine, we have the bile duct and the pancreatic duct that exit out of the same opening. And so this organ right here, hiding back here that I've drawn out, this is the bile duct, this is the pancreatic duct, and this chicken tender-like organ is the pancreas. So most commonly, masses can happen in the head of the pancreas, which is here closest to the duodenum, the small intestine. And the Whipple procedure, or the pancreaticoduodenectomy, is essentially a surgery where they remove this type of cancer right here, and they remove these structures. So the pancreatico stands for pancreas, and the duodenectomy is the part that they remove the duodenum, or this part of the small intestine. And I'm gonna throw up a picture right here of the final result after they reconnect the rest of the pancreas to allow for some of its function to still work, and also how they reroute the gut so you know what the anatomy looks like after the surgery has been done.
This hospital sees those maybe once every 6 months.
So this was filmed a while ago, I understand. Now if you ask the chair of surgery at the institution I work at, he's probably done the most Whipples, if not close to the most Whipples in this country. And last year he hit the 1,500 mark, and I think he's probably gone past 1,600 or 1,700 at this point. So we definitely see many more Whipple procedures being done at our institution than once every 6 months, let me tell you that.
That's why you got here at 4:30, huh?
4.
Grab my chart before anybody else could see it. Press Dr. Burke with your pre-round exam. So you'd be the logical intern for him to ask to scrub in. I know all the tricks, Doctor.
Yang. Christina Yang.
I don't know if this really happens, that the doctors cherry pick which trainees they want to actually work with. At least for me, everywhere I've trained along the way, it's always been an equal opportunity situation based upon a predetermined schedule.
I'll call you Christina. You call me Nurse.
All right, I like that sass. I like how she's establishing the fact that the doctor, the intern, is going to be called Christina, but she has to be addressed by Nurse Fallon.
55-year-old woman with adenocarcinoma of the pancreas has had radiation therapy to reduce the tumor load. Rates for abdominal pain 3 out of 10. Positive nausea but no vomiting. Diarrhea, hematochezia,
melena. She's mispronouncing that a little bit. So we all have a general idea of what diarrhea is. Now hematochezia is red blood in the stool, whereas melena is black tarry stools. So hematochezia usually clues us into a bleed that's coming from a lower source in the gut because we're looking at fresh blood. Whereas melena clues us into something that's higher up in the gut, maybe the esophagus or the stomach, because there's been enough time for the blood to be digested and come out looking like black tarry stools. At this point, we now know that she has pancreatic adenocarcinoma, which is the most common type of pancreatic cancer, but I'm not quite sure how they diagnosed it.
Tmax 37.2 and stable vital signs. Lab significant for a total Billy of 7.
So Dr. Yang here is presenting the patient to a senior or an attending physician who's the head physician of the team, give a rundown of the updates of this patient. So whether it's a new patient or someone that we've been following day to day, we usually start off by giving a brief history and saying how the patient's feeling at the moment. Then we go into reporting the vital signs and the physical exam, as well as lab values, which is exactly what she's doing here. So the T-Billy or total bilirubin of 7 with the elevated liver enzymes is very important for us to report here because it basically clues us into the fact that there is backup of bile, an accumulation of bile, and an effect of the bile backing up into the liver. Given the circumstances, it sounds like the pancreatic tumor is now blocking off the bile duct, which is why she's reporting that information. When we see the T-Billy at that level, we usually expect jaundice or yellowing of the skin, or scleral icterus, which is yellowing of the eyes, which this patient actually has in this scene. And sometimes with that accumulation of bile, you can also get itchiness, and these are all reasons for us to go in and try to open up the blockage being caused by the tumor if surgery isn't going to be done immediately, or if the patient isn't a surgical candidate.
Thank you, Dr. Yang.
Aggressive little witch, isn't she? She stole my chart during pre-rounds so she could scrub it on my surgery. She's hoping for a Whipple.
Well, actually, Liz, I was going to give you the Meredith Grey, but I guess you've got the Whipple.
I'm gonna need a full blood workup and abdominal CT.
CTs are down this morning.
Then an MRI. She needs an enema, and ERCP for a stent, and brush biopsy this afternoon.
Okay, so first of all, let's talk about the CT MRI situation. So a CT scan, for those of you who don't know, is cross-sectional imaging of the belly, which lets us look into the belly and see, where this tumor is, etc. Usually, CAT scans happen pretty quickly because there are multiple of these machines at big teaching hospitals, and they usually only take a couple minutes to do, rather than an MRI where there are fewer machines and they take much longer to do. There tends to be a backup of patients for MRIs. So this scenario isn't very realistic in my eyes because CAT scans are much easier to come by. Chances are the MRI is going to cause the patient to wait for much longer, sometimes even days on end at some of the hospitals that I've trained at. The other thing that he was asking about is for an ERCP, which is short for endoscopic retrograde cholangiopancreatography, which is a very fancy term for when we go into the stomach and small intestine using an endoscope, and we look for the opening that the bile drains out of, and we go into that opening into the bile duct to place a stent or something to open up the blockage that's being caused by the tumor blocking off the bile duct and leading to that accumulation of bile in our system. He was also asking for brush biopsies, which isn't typically how we go about diagnosing pancreatic cancer. And if they already have a diagnosis of pancreatic adenocarcinoma, I don't know what the purpose of brush biopsies really are. So usually how we go about diagnosing pancreatic cancer is doing an endoscopic ultrasound, where we can look with an ultrasound internally through the wall of the stomach or the small intestine into the area of the pancreas, and we can pass a needle into the tumor and take some tissues out to diagnose the pancreatic cancer. We do this to really confirm that this is pancreatic cancer that we're dealing with, because sometimes certain things look like masses but are actually benign and don't require the patient to undergo such a lengthy, complex surgery. Believe me, you wouldn't want a Whipple if you didn't need it. But the endoscopic ultrasound also lets us look if there's invasion into vessels, if there's spread to lymph nodes, and that helps the surgeon determine what they're gonna do. It helps the patient sort of understand their prognosis, and sometimes in appropriate situations decide if pursuing treatment is the right thing for them, especially if they're very sick or elderly to begin with. Maybe putting them through all of this might not be the best idea if the prognosis isn't good to start with. So it's always a conversation with the patients to understand what their preferences are, what the goals of care are, given all of this information. All right, that's it for today. Please let me know if you have more things you'd like me to react to in the comment section below. Don't forget to give this video a thumbs up if you enjoyed watching, and please subscribe by clicking the red button below. You can follow me on all my social media, which I'm gonna list in the description box. And until the next video, please stay healthy. I will see you next time. Bye, guys.